could be included in more than one reviews. We calculated the percentage overlapped primary studies included in reviews using the corrected covered area method. So turning our attention now to the results. So 15 review, we included 30 reviews in our overview, and half of reviews included people with dementia, and 3 reviews, people with Alzheimer's disease were included specifically in 3 reviews, and 5 reviews included only people with mild cognitive impairment. And the mean age of participants was higher than 60 in most of reviews and higher than 70 in more than half of reviews. And the percentage of only one review reported that the percentage of male was slightly higher than that of female. And as you can see, most reviewers prefer to investigate the didn't prefer to investigate the effectiveness of a specific type of exercise. So as a result of quality assessment, only one review was found to be high quality, which is a coherent review published in 2015. 8 reviews were interpreted as low quality, and 21 reviews were interpreted as critically low quality. So why? Because they didn't provide satisfactory explanation for study design. They didn't provide the list of excluded studies, and they didn't register the protocol of reviews. So 14 reviews included in the review, and according to 14 reviews pulled the data from primary studies, and they showed that moderate effect size ranging from 0.27 to 1.44, and only one review reported that no significant results. Others showed that multi-component functional exercise could be more effective in improving ADL. Out of 3 reviews, 1 review suggested that mind-body exercises were not statistically significant, more than significant than control intervention, but others suggested that functional exercise can help in improving walking speed and distance. All reviews reported positive effect of exercise on balance, especially exergame, functional exercise, and mind-body exercises. For visual processing, reviews only included visual spatial function, and they reported that dual tasking or multitasking exercises could be more effective in improving visual spatial function. So we found that moderate intensity multimodal exercise program or combination of a cognitive and physical training program could be more effective in improving that outcomes in people with dementia. And our results were consistent with the previous overviews. For example, McDermott suggested that multimodal exercise with moderate intensity could be more important in improving ADL and walking. So although this review provides a comprehensive synthesis of evidence from a range of exercise intervention and available best evidence, some unique limitations should be mentioned. High heterogeneity between reviews made it difficult or challenging to interpret the result, and we found moderate overlapping, range from 4 to 6, and high-quality systematic review and meta-analysis should be conducted, especially a network meta-analysis. I haven't found a network meta-analysis including physical outcomes. So, multi-component exercise is a broad definition, and it should be the context of this program should be detailed with high-quality randomized control trial. So thank you very much. Here is the QR code if you want to read full text of this paper. And I want to take this opportunity to take my the other authors of review, my supervisors Yves Hogervorst and Thomas V. Coxon, and my colleague Manisha Jain. Thank you very much.
Thank you very much for this very thorough review. And questions will come later. Thank you. Okay, and I now want to introduce Suzanna Dooley. She is from Trinity College in Dublin, and I didn't welcome those who are following this session via the video streaming, and I would like to welcome them as well and to pose their questions in the chat. So the floor is yours.
Thank you. Good afternoon, everyone. I'm delighted to be here in Bucharest presenting our research on conversation coaching in dementia. I'm here with my colleague Sophie Fury. We're both speech and language therapists. We work in a hospital in South Dublin, and we've partnered with Trinity College Dublin to do this feasibility study. So going back just firstly to the nuts and bolts of communication. So we know that communication and language are cognitive skills. However, in the research, we see a lot about memory and cognition, and sometimes communication and language is a little bit neglected. And we know there's a very definite but sometimes subtle relationship between language and cognition. So these are the different cognitive communication skills that are impacted when somebody has dementia. So quickly just going around the circle, looking at attention, so our ability to focus on a conversation, divide our attention between different stimuli, being able to process information. And by that I mean visual information and also auditorily the information. Being able to understand then from a language point of view. So language is multimodal, so we're looking at the person's ability to talk, to understand, to read and write. So a lot of different impacts on language. And we know from working with people with dementia that each person with dementia will have very unique communication profile. So it's not one size fits all. So we have to look at all these different aspects of communication in order to determine what the person can do well and what are their retained communication abilities. We know very much so that memory impacts on a person's ability to communicate, their ability to process what's been said in the conversation, what's gone before, what they've said themselves, what they might say next. So keeping track of all that is quite complex. One's ability to reason, so to weigh up what's been said. And then the executive skills, pulling it all together in terms of the conversation, managing conversation one-on-one and also in groups. So we as speech and language therapists are very cognizant of the fact that our ability to communicate affects our quality of life, how we interact with others and maintaining relationships. The study done by O'Reilly in 2020 also kind of points to that. They identified 13 outcomes that were identified by people with dementia as important core outcomes in quality of life measures, and 4 of them happened to be communication related. So being able to communicate, being able to see, hear and understand, and being able to maintain relationship with others, as well as being able to have a laugh with people. So in terms of the published research, there's very little out there on using conversation therapy with people with dementia. So we need to borrow from other areas. So we're looking to the physiologists in terms of Nina Simmons-Mackey, Ora Kagan, and Sarah Locke from the UK. So what is conversation coaching? So it's a direct plan treatment that's designed to enhance conversation skills and confidence. Our own definition, what we've added in is conversation coaching is conversation therapy. So that involves working with the person in the context of genuine conversation. So either in the clinic or getting the client to bring in videos from home, that little chats they might have in the sitting room or in the kitchen table, and that we look at those together and we evaluate how people are getting on in their daily conversations with significant others. And then also that element of communication partner training. So we know that communication partners are very, very important in scaffolding conversations, and what we do as part of our coaching therapy is helping the communication partner, and by partner I mean supporter. It could be a spouse, a family member or a staff member, in putting in communication supports, adapting their own communication to help the person with dementia. But to what level do you adapt? So you don't want to go in, if somebody's got early dementia and they just need you to do small things like alert them or slow down, that's fine. But maybe as dementia advances, they need to enhance the level of support they give. So helping people to understand how they're doing and what adaptations they need to make. So in terms of conversation coaching goals, what were our goals? So to provide education for the participants in the group, to also to provide psychosocial support, and to help people become aware of what's working well in their conversations and getting them to do that more, and also then identifying what the barriers are. To identify and practice self-generated strategies. So these are the kind of the bridges that we had, this theme in the conference, these bridges to better communication. So what communication supports people can use. And then to encourage the participants to remain socially active outside of the group and in their own communities. So our feasibility study was to investigate the feasibility of this intervention, looking at CCI in terms, is it feasible for people with dementia? Does it change their communication function? Do they meet their own communication goals after being part of the intervention? And does it impact on the well-being of the person with dementia and their communication partner? So it was a perspective within subject design. We had 34 participants in the group who were all people who were part of our caseload in the hospital and the outpatient caseload. The intervention framework was one-on-one with clients as well as the group sessions. And it was run by 2 speech and language therapists over a 6-week period. So what were the outcome measures we used? The communication measure we used was PCAD, which stands for Profiling Communication Ability in Dementia. It's a very new communication tool. When I say new, it's just been published today. So it's available for purchase today. And it formed the basis of my PhD research over the last 5 years. And it was validated with 120 people with dementia in Ireland. Again, the whole idea of PCAD is looking at the person's profile, their individual strengths and weaknesses, and building on what they're doing well. And then helping the partner to put in I suppose, the specific supports. The other communication outcome measure we used, or it was quality of life measure, was the ICE-CAP from the University of Bradford. And that looks at it looks at 5 core concepts of quality of life. And then the goal attainment scaling where the clients actually got to generate their own communication goals before the intervention. Okay, so our participants were all people with dementia. They had mild to moderate cognitive communication difficulties as identified by the PCAD. And they had to be able to come to all the sessions with a communication partner. We had people with different subtypes of dementia in the group, fairly equal mix between men and women attending. And then our communication partners, the majority of them were people's wives, and then we had some sons and daughters as well attending. So here's an overview of conversation coaching. We have our group sessions and our individual sessions, and you can see the group sessions are very much kind of educationally based, looking at how communication impacts dementia, looking at people's individual communication styles and learning more about how to interact better with the person with dementia. And then going forward, looking at building communication networks and building on, I suppose, gains made as part of the intervention. As I said, the individual sessions are based on the video footage brought in by the clients into therapy. So our results, we ended up with 28 participants. Again, this research ran through COVID, so it was a little bit tricky to hang on to people and get them to come into clinic. So we lost some participants along the way, and they were retested at 3 months. So looking at the PCAD, which was a communication profiler, and what we found was that 3/4 of the participants maintained their cognitive communication ability after the intervention, and 25% of them stayed the same, and nobody deteriorated, which was very positive. In terms of the well-being of people with dementia, we found in terms that 25% of them felt the same, and then 75% felt they had improved and that quality of life after the intervention, which is very positive. In terms of the communication partners, likewise, we had 80% of the communication partners felt after the intervention that their quality of life had improved, and 20% had stayed the same. There we go. So what were just having a look at some of people's individual goals. So people with dementia had said they wanted to meet others in the same boat, to understand each other better in conversation, to support conversations, to support the person in conversation with others, and to learn from the experience of others. And to learn more about dementia. Sorry, I'm going closer, I can't see. and to keep track more in conversations, to be more involved in conversations, and to be able to manage my word-finding problems in conversation. So again, looking at the goal attainment scaling, quite positive outcomes. The majority of people with dementia felt that they met their goals to an expected level, 10 of them, and 4 people said it exceeded their expectations, and likewise with the partners. So the themes of their goals for communication were really very simple. They wanted to improve their understanding of the impact of dementia on communication, they wanted to improve their communication, and they wanted to share their experience with others. So here's some feedback from the participants. After the therapy, we had a focus group. Today I'm not presenting the results of that, but just to give you a little snapshot. I don't want to worry too much now. I just give it a go, and if I can't do it, I come back to it. Because of the intervention, I've told the lads about my dementia. I enjoyed it all right. It does no harm to think about this stuff. And then from the partners, it's useful to meet others, not only to see you're not alone, but to see how well you're managing. Thank you. It was extremely helpful, understanding, life-giving and supportive. I feel everyone joined in and had the opportunity to say their piece. So our key findings, CCI is a feasible intervention for people with dementia because communication ability as measured was either maintained or improved after the intervention. The well-being of participants was also maintained or improved, and all communication goals were met. The feedback from the participants indicate that this is an acceptable intervention, and it's a collaborative approach to conversation therapy, building on retained communication abilities in people with dementia. So here's the PCAD profiling tool, and it's available from supportingcommunication.com. And also, if you're interested in more in the work of speech and language therapists, this is a free online educational tool that's available through this website here in Ireland. It was created in St. James's Hospital in Dublin, and it's an education, 2 education modules for speech and language therapists and for occupational therapists working in dementia care. Thank you for listening.
Thank you very much for sharing this very important intervention with us to help people to stay into contact with other people, to give the means to it. Thank you very much. So the next speaker is Phébe, and she is from Radboudumc University. Actually, we are from the same university. The floor is yours.
So, good afternoon, everyone. Thank you for being here today. Self-direction among people with dementia. How great would it be if every person with dementia could experience a little part of self-direction? But is this realistic thinking? My name is Phébe. I'm working at the Department of IQ Healthcare from the Radboudumc University in the Netherlands. And the next 10 minutes I will present the SOCAF program I've worked on during my PhD. So SOCAF is a psychosocial intervention based on the COTID program, so Community Occupational Therapy program for people with dementia and their informal caregivers living at home, and Colorama reflective coaching for nurses. The aim of the program is where we want to explore and promote the self-direction, wishes and opportunities of meaningful occupations for people with dementia. We want to achieve this by a training and a coaching process for the informal caregivers and the nursing staff, where we focus on person-centered communication and observation strategies. To make it a little bit more visual for you, we start with this SOCAF program with a training for informal caregivers and nursing staff. We provide a little bit more knowledge about dementia and also give them a simulation suit to experience how it is to be vulnerable. Furthermore, we introduce the concept of self-reliance and make them a little bit more of person-centered communication and observation strategies. After the training, we move on to the reflective coaching part. Together with a SOCAF coach, the nursing staff member will look at themselves and reflect on the working situations from the previous period. They go through the following questions. Where was I satisfied about in what I did myself? What should I do differently next time? And what are some learning goals for the next period? During this session with the nursing staff members, we will make them a little bit more aware of the method observe, act, observe. And what do we mean with this? During the intervening period between the coaching sessions, the nursing staff will observe the behavior of the person with dementia. What is the situation about? What are their needs, wishes, and habits? And if you have observed it, the nursing staff member chooses an action based on this observation. And after this action, a really important one is the last observing part. Has my action given the desired effect, or should I do something else? To give a little example, a person with dementia, a lady with dementia who is restless and talks a lot, walks back and forth when you come in the home. This is the observation you have. And then what do? Do you stand in a doorway and just try to make contact with her? Or do you verbally try to lure her towards the shower because you have to shower today? Or do you sit at the table quietly and just hope the lady will come and join you so you can have a little talk before you move on? It doesn't really matter which action you actually will do, but it's really important to observe afterwards, has my action given the desired effect? Or should I choose another action? And then reflect again. As a third component, we have added the home consultations in the home setting. So the person with dementia, the informal caregiver, and the nursing staff will talk about shared problems, wishes and needs they have, and where they would like to work on by directive supportive interviewing. The SOCAF coach can help the nursing staff by the talks during these home consultations. Where was the study about? So in 2016, we started implementing this intervention in the nursing home setting. The results were actually quite positive, where we saw nursing staff members changing in their behavior. And also persons with dementia started to do some activities again, which they haven't done for a long time. With these positive results and the feedback of informal caregivers, where they said we should actually wanted this to know a little bit early in the process, we came with the idea to implement SOCAF in the home care situation. We first did a design feasibility study to adapt this nursing home intervention towards the home situation by exploring the needs and wishes of the different stakeholders. Afterwards, and last year, we did the feasibility effect study, where we explored during 12 months the different changes in attitudes and behavior. We collected the data among the people with dementia, informal caregivers, and nursing staff members, and we did it by doing individual interviews, focus groups, and coaching diaries. Then maybe most important, what did we find? Among the participants with dementia, we saw that they were satisfied with the directional supportive talks. They've report feeling heard and respected in making their own choices. From the informal caregivers, we saw in the beginning of the process, they were a little bit more direct and also controlling towards the person with dementia, purely actually to ensure the safety. During the process, we saw them more being able to create some circumstances for the person with dementia, where they can make their own choices. They started to recognize their own behavior towards the loved ones and try to stay more close to the needs by not controlling or correcting them all the time or taking over when they were visiting. At the beginning, we also saw the informal caregivers who mainly tried to manage the situation, like living in the here and now, and they also have some fearness about what is still to come in the future. After attending the informal caregiver training, they were better able to name their own needs and had more insight in the process of dementia. And towards the end of the program, we saw that they have become more at ease with the situation. Among the nursing staff, we saw at the beginning that they are searching how to make contact with these people with dementia. What do I find behind the door today? Later, they start to make more use of what they observe in the current situation, learn to ask open questions, and listen to the underlying core. They dare to respond more flexibly to the current situation. The concept of self-reliance turns out to be complex after all. At first, we see this association with own choice, independence, self-management, and they say actually it doesn't really fit with dementia, in dementia care. And they want to perform the tasks that needs to be done, like task-oriented working. And this puts the person with dementia a little bit more in the passive role. We saw a change during the process. There's a more awareness of the focus on how they can support and maintain their self-direction, and more a co-direction occurs. So how can I support without taking over? And furthermore, we saw the nursing staff members realizing that they are working on automatisms and try to listen more, finally, and have a less solution-oriented directing attitudes. Finally, if we reflect on the process, we saw this reflective coaching was quite helpful. You have to give some safety and comfort to start this reflecting. But it takes time. Reflecting on yourself is quite difficult at the beginning. But it's nice that a nursing staff member starts to discover what he or she really does to encourage this self-direction. A very important thing that the nursing staff member mentioned is that what works today does not necessarily work tomorrow. It remains important to keep looking at the current situation and reflect on your own actions. And finally, self-direction, or maybe agency, or self-reliance, or self-determination. We're not sure how to really name it in English. See it small. Look at the needs, wishes, and routine of the person. It does not always have to mean that the people have to do or can do something by themselves, but it can also be done together. Thank you.
Thank you very much, Phébe. This is a beautiful example of research in progress, of following on previous research, on following on previous interventions. And in fact, you are a kind of scientific granddaughter of mine because your supervisor is Maud Graf, who was my PhD student. And our next speaker is Lizzy, both very well known within Interdem. And and she is from the Maastricht University. I immediately give you the floor.
Thank you very much. And thank you everyone for still being here. I know it's late and everyone wants a drink, but I hope you can still listen to what I have to say. And later on we'll have a drink together. So I'm very pleased to be given this opportunity to present the findings from a group session that we did, actually, that has been delivered for many years now in clinical practice. We're looking into cognitive factors to see if they predict intervention success for a cognitive behavioral group intervention for people with MCI, or Mild Cognitive Impairment. And in the Netherlands, we call it the MCI group. Well, I think everyone knows in this room that to date there is no cure for dementia available yet. But at the same time, there has been made a lot of progress in delivering timely psychosocial interventions. And they actually help people with dementia and their caregivers to adapt to this continuously changing situation and adapt to their cognitive, practical, and emotional problems that they encounter. And to optimize the effectiveness of these types of interventions, more knowledge is very important about response characteristics to really know which type of intervention works for who. And to prevent overburdening for the caregivers and also help people with dementia adapt to their challenge that is dementia, timely intervention is essential. And in timely intervention delivery, we can immediately think about people with MCI or mild cognitive impairment. These people, actually MCI refers to the state between normal aging and the clinical state of dementia. And people with MCI are a very heterogeneous group, so a lot of different types of people. Cognitive deficits are in various degrees in this group of people, and also descriptive subtypes of MCI. I'm not sure if people here work with people with mild cognitive impairment. Some people say MCI doesn't exist, other people say MCI does exist, but there are criteria made up by Peterson, if you maybe you can read up about it, and they say that there are very different types of MCI that you can diagnose people with, based on, well, actually the nature and the extent of the cognitive problems. And considering the heterogeneity in this group, so there are very different types of MCI, it's really highly unlikely that every intervention will fit every individual. So as already mentioned today, one size does not fit all, also in this group. So the severity and the range of the cognitive problems could influence both the adaptation and the coping process, as well as the ability to process and apply the offered information that has been given in this intervention group. So really the severity and range of cognitive problems could predict intervention success. And in terms of MCI subtypes, especially the multi-domain MCI is of interest. So that's being associated with the more advanced disease stage, and also a higher annual progression rate and the lowest proportion of reversion to normal cognition. And in this study that we did, we explore if cognitive factors are associated with psychosocial intervention success. And we hypothesized that people with multi-domain MCI, more global cognitive problems and more severe episodic memory problems are less likely to profit from this MCI group. This is the boring part, of course, the methods, I'm sorry. This study was used a non-randomized within-subject design. So participants were recruited in the MCI group in Maastricht University Medical Center in the Netherlands, and also in the Alkerlijk Hospital in Helmond, also in the Netherlands. The 54 people with MCI assessed the pre-post intervention. And we use a standardized clinical rating scale, the CIBIC Plus, as a primary outcome. And this actually takes into account individual differences and measures clinically relevant change. And descriptive subtypes of MCI were amnestic, non-amnestic, single and multiple domain MCI. We determined these subtypes based on the neuropsychological profile plus a clinical interview as suggested by Peterson. And the global cognitive function was measured by the MMSA, the mini mental state examination, probably known by everyone, and episodic memory with the Ray verbal learning task. Sorry, I have to read a little bit because it's not my study. Okay, the group consisted of 5 to maximum 8 participants, and there were 8 weekly 2-hour group sessions. And 3 months after completing the intervention, there was a follow-up or a booster session. And all sessions were delivered by a clinical healthcare psychologist and a co-therapist. And in addition to the group sessions, there were also 3 individual sessions, so prior to the group, halfway through, and also at the end, together with a significant other. And in these individual sessions, the personal experiences were discussed, and also the personal goals were evaluated. Each group session had a similar structure around a specific topic. So it started with an introduction to the topic, a little piece of psychoeducation for 30 minutes, then the most important part, the coffee break, self-management with assessment, and practical exercises that lasted for 60 minutes. And it was based on the Dutch model developed by Liesbeth Joosten within the Radboudumc. Yeah. Well, the main goal of this intervention was to teach participants skills to allow them to cope with the consequences of having MCI, particularly with the insecurity and the loss of grip and the feelings of anxiety for conversion to dementia. And to improve self-efficacy and also translation to daily life, participants were asked to discuss every session with their significant other. And to promote this, they were given a written summary of every session. Okay. Well, in the results, we looked at responders and non-responders to the intervention. Responders were those who scored from 1 to 3 on the CIBIC, so from very much improved to minimally improved, and non-responders were the ones who scored from 4 to 7, so from no change to severe worsening. And post-intervention, we saw that more than half of the group improved, and the other half remained stable. And we saw no scores of 6 and 7, and only a few had the score of 5. An MCI multiple domain, so the subtype MCI multiple domain was associated with a negative intervention response, which means that people with multiple domain MCI did not profit from the intervention. And cognitive functioning and episodic memory was not actually statistically associated with intervention outcome. Well, why did we find this? Well, it could be that the descriptive subtypes of MCI have a better association with clinical functioning, so not only the cognition, but also the daily functioning and the behavior in daily life. Now, because the neuropsychological measures like the MMZ and the Ray-verbal learning task may not have this association with daily life. And with the insecure nature of MCI, and the focus of our group intervention on accepting insecurities and uncontrollability, psychological characteristics such as acceptance and mental resilience could be also predictors of intervention success. This is also seen in other studies like chronic pain studies. So the interaction between psychological factors, coping, and cognition should be really the area that we should look into in the future. This would be of great clinical value. Okay, I will wrap it up. To conclude, MCI multiple domain is associated with less profit from the cognitive behavioral group intervention compared to people with single domain MCI. And people with multiple domain MCI could profit from another type of intervention that is less cognitive demanding, like an individual intervention that focuses more on adapting the environment. So probably also more on helping caregivers how to cope with the disease. An MCI subtype is more predictive of intervention success than measures of global functioning or measures of verbal episodic memory retrieval. Okay, and now this area of research may offer valuable insights, so we should all have more studies in this area, because the effectiveness of the healthcare intervention delivery will improve if we gain more knowledge on which intervention works for who. Okay, well, thank you a lot, and I also want to thank the participants for helping us gain these results.
Thank you very much, Lizzy, and for going to this very complicated, challenging question of what works for whom. And you also learned something more about person-centered care. That's not as simple as we state. Now I haven't seen, but I'm happy you are here. And well, you have 10 minutes. You have 10 minutes.
10 minutes. Okay.
Yes.
Okay. Yes. Hello, everybody. My name is Ümran Sema Seven. I'm PhD at the University Hospital of Cologne, and I'm pleased to present our study development of the presentation is not here. Important. Okay. Yes, yes. Okay, thank you. Yes, I'm pleased to present our study development of a cognitive stimulation program for care facilities results from a qualitative study with nursing staff about desires, limits, and possibilities. Cognitive stimulation is an intervention for primarily for people with mild to moderate dementia, and the goal is to stabilize the cognitive and social skills. And cognitive stimulation is usually is a multi-component intervention which includes exercise and relaxation, and games, communication, music, and occupational therapy, cognitive training, and multisensory stimulation. And in meta-analyses, above all, as an overriding method, reality orientation and reminiscence therapy are also combined with this type of activity. And in meta-analysis, there are many positive effects shown, like on a global cognition, quality of life, and well-being. Also, cognitive stimulation is recommended in guidelines for people with dementia. It's all also these interventions are each an add-on in the care of individual people with dementia. Sorry, I'm very excited. Sorry. In general, cognitive stimulation is a program usually implemented in a group setting, and approx 5 people. And implementation in a one-to-one situation is also possible, but rarely. And due to COVID-19, you all know that social isolation increases, and the group settings the group offers are not possible in nursing homes. This means also, because it's a group setting is very prominent, that bedridden residents are not able to take part in this kind of intervention. And this leads to social isolation, and this increased depression and loneliness. This made clear a concept that accompanies everyday life and facilitates cognitive stimulation, especially in communication with the professional caregivers and residents with dementia has been lacking until now. And this is where our project comes in. The overall goal is to develop a cognitive stimulation, an everyday cognitive stimulation program tailored to the needs of the care facilities. And today I focus the qualitative study, but we have another steps and sources which form the basis of our cognitive stimulation program. And the target groups are nursing and care staffs and nursing home residents. And we want to train the nursing and care staff and make a feasibility study. Yes, today I focus the results of the qualitative part, and we want to explore the status quo of cognitive stimulation in nursing homes and gaining a multi-perspective understanding of nursing and care staff in terms of desires, needs and barriers, as well as feasibility with regard to the cognitive activation of residents. And we want to generate some ideas for the cognitive stimulation program, which should be used in every day. This part, we have conducted telephone interviews and focus group discussions, and we have included 4 nursing homes for the elderly, and in summary 13 people for the nursing homes participate, and 12 people from the social services. Some main aspects of our results are status quo, needs of residents, needs of nursing and care staff, and barriers. And the material is very comprehensive, and I will only give some experts. The first, status quo, what takes place in the facilities. The participants, or professional care, nursing, care staff emphasize the importance of communication, and they say you can't just take a care of resident, wash, put lotion on without saying a word, and I think that takes place automatically already, no matter what you do. And they combine often reminiscence therapy and reality orientation in their talks, and to the status quo, they promote the independence in personal hygiene, and group offers are most in the area of music, movement and memory training, and they also stimulate in everyday life, like singing, writing shopping lists, and another. And above all, they say that the cognitive stimulation must be seen as a meaningful and give a good feeling to the residents. The status quo is an unanimous demand. Cognitive stimulation should be given more space in everyday life, say the care staff, and positive effects of cognitive stimulation on the residents with dementia are very clearly recognizable. Residents are much more balanced and satisfied, which also has an effect on the staff. This is very important. And the staff say, if you don't occupy a person with dementia, he occupies you. That's just the way it is. And they say, if there are many offers for the people with dementia, there are less sedation needed. And yeah. The needs of staff is they all participants say time, more staff, and content related to the cognitive stimulation. They say I could use such small impulses myself to engage them, the residents, much more quickly and in the short term with something new. They are missing in their everyday work. And wishes if everything was optimal. Music is a door opener, and they say they want to form a choir or a band, and they enjoy this. Necessity, also we have asked the participants who should be trained, and they say all persons who come into contact with people with dementia, also cleaning staff and kitchen staff and they wish that there is an informative way and a practice. And to the relatives, they say they had also been trained because there is a lack of knowledge about dementia, and this is very specific. And difficulties in the implementation. They say lack of manpower, lack of time, and pressure. The residents say, you are flying by here, always. You are just racing. And this is a really important part. The care staff say, I'm really quite honest now. Unfortunately, I find that the residents with dementia who perhaps would also need it are often not taken along at all because it is said there are nuisance. The residents perceive it, and they ask, why can't I go? Why he is going and I'm not? And they say also that missing material is a topic in the care facilities, and personnel are not there, and material are unused, and group size of the group offers are not optimal, and there are some limitations, but I have not time. And this is a conclusion, vielleicht a conclusion. This participatory approach was fundamental to the development of the cognitive stimulation program. Thus, implementation of this everyday life accompanying cognitive stimulation approach for people with dementia in care settings is promising. And if you need much more information, there is a virtual oral presentation of my colleague, Dr. Volkerts. Thank you. I'm sorry.
Thank you very much, and also for sticking to the time. Thank all of you for sticking to the time. Can you stay here, please? And sit here, and I want to invite all the speakers to sit here. And what I want to add to your presentation is how important it is to have an intervention which is carried out in regular care. That's really an important thing, and how to communicate in daily care. So thank you for this. Okay, and now the floor is yours. Please pose your question and state for whom your question is. Yes, the first question over there. Oh, so I'm going to walk.
Thank you. Thanks, everyone, for your fantastic presentations. We've been speaking about pretty much mild cognitive impairment, and it's for the first speaker. I'm just wondering why the age is 60 plus, because there's a lot of us with dementia, and we haven't got to 60 yet. I'm sure I'm close, but we haven't got there. And I think you're losing out on a lot of valuable information for people in their 30s, 40s, and 50s that haven't hit the 60 mark, and especially for mild cognitive impairment. So I'm just wondering why, because I've seen it so often in studies that it's 60 or 65 plus, but the younger onset people seem to be left out. And it's the same with photographs. We see old hands, we see old elderly people, you know. Now maybe I'm kidding myself, I don't feel I look that old yet, but I'm just wondering why our study is that 60 plus. Thanks.
So, actually, we did a secondary, we did an overview of reviews, and most of review included primary studies. So, yes, as you said, it makes the results make it difficult to generalize the results to the whole population, and also it make the heterogeneity high, because Yeah, mild cognitive impairment can start earlier, and most of studies include older age group. Therefore, but it's a little bit difficult to recruit participants lower age group because I think it's my opinion. Most of them aren't diagnosed yet, and they don't accept their cognitive impairment maybe, and as maybe timely diagnosis. Therefore, it's really important, and then we can recruit more participants in lower age group. But it's another limitation of my overview that these results cannot be generalized because of that age group. Therefore, I report that age group, actually.
Thank you very much. Next question.
Just a question for Omran with regard to the cognitive stimulation programs. Have you looked at the advantages or maybe even potential disadvantages of one-to-one programs as opposed to group or collective therapies?
I think in all our centers we work with individual and group sessions, and I think there are many advantages, disadvantages for both options, but that it's really important to look at what people want themselves. Do they want to be part of a group? Do they want individual sessions, or do they want a combination of both? So I don't think that you can say, well, this is best for all people with MCI or dementia, or just really make it tailored and see what people want themselves. But the advantage of a group is that you can learn from each other and that you have that peer support.
Yes. And well, to continue this discussion, are there disadvantages of group interventions?
Should I say it as well? Well, this is not scientifically backed, but I'm just thinking out loud now that I think disadvantages of group sessions are also that there's not a lot of room for your own process, so for your own goals, your own journey. Sometimes other people are speaking a lot and there's not a lot of room for your story, but I think in the experience that I have with the group sessions, that if you keep them small, then there is room for everyone and they all help each other out. So I think they also have a very big advantage in that way.
Well, yes, okay. Yes, I will respond on this. From my own interventions a long time ago, we learned that the disadvantage of group interventions can be that people frighten each other, so that they hear the story and they get frightened instead of they feeling helped. Yes, please.
Thank you. According to your experience, I'm talking to Dr. Boots, if I remember your last name well, which would be an appropriate or at least helpful psychotherapeutic intervention for people with MCI multiple domain? Okay, you said that cognitive behavioral therapy is not fair enough, it's not helpful enough in this population. So do you have something else in mind?
Yeah, what we got back was that it would be better to have an individual intervention, so not a group, because it's too cognitively demanding for people with multiple domain MCI, and also to support the environment more to cope with MCI and help people adapt to their situation, not only the person themselves, but also their caregivers. So more individualized, less cognitive demanding, and also caregiver support.
Next, oh, and then
also a question to you, Dr. Boots. So, I mean, you kind of grouped the MCI patients with like multiple domains, single domain, but I was also wondering, I had the feeling that you saw the MCI patients more on the continuum to dementia, but MCI, as far as I know, does not necessarily mean that a person develops dementia. And so I was wondering, did you look into the etiology, or did you have like information that you based your decision on to include like the patients, or to assume that they probably are like struggling with the fear of developing dementia?
Yeah, it's a good question, because you're right, a part of the group does not convert to dementia, and they can even cognitively improve, right? But we didn't select only the people due to AD, for instance. It was really also up to the people. If you have a diagnosis of mild cognitive impairment and you have these fears, even if you don't have the etiology, then you could actually benefit from the group session. Because it's not all about what happens if you convert to dementia. It's actually all about coping with insecurities. And I think whether you will convert or not, these insecurities will remain. So we don't select.
Thank you. Yeah.
Thank you very much. It's quite a specific question for Ahmet from the first talk. Why did you only include studies from 2015 onwards?
We just wanted to include recent evidence published after 2015 would, like we thought, 5 years, because we did the we searched the literature last year, and we thought 5 years would be could be included as counted as recent evidence. Therefore, we put a time limitation for that.
It's about communication coaching. You said that you were happy that there was not a decline, that they were just as good or as bad as they were when they started the coaching. So how long was the coaching period so that the decline could be expected in that period? Another question. I heard somewhere in your presentation that you said you picked people from a waiting list. Am I correct? What, waiting for what?
So people who are waiting to come in for speech and language therapy intervention. Everybody was offered the therapy group, but those who want to be in the feasibility study, they had to select to come into it. So we had over 6 weeks the sessions were run, and then the reassessment was done at 3 months. So the reassessment was looking at not just their communication ability in terms of linguistic, but also the adaptation of the communication partner. So sometimes their score improved. That may have been due to the fact that the partner had adjusted their communication style to work better with the person with dementia. So it is all about enabling the couple and the dyad to have better conversations. Does that answer your question?
Okay, then we will end this session. It's nearly 6:15. Thank you very much for your active attendance. Thank you very much. And thank you all very much for your very interesting psychosocial interventions. I thought I knew a lot of it, but I'm still learning, and that's a joy, and that's I want you to do as well. Thank you.